I'm going to just introduce Dr. Wimberly, who's from Atlanta, an adolescent medicine specialist, has some experience, although limited in corrections, but has extensive experience in the Atlanta area with health equity issues. And I'll tell everybody that this is being recorded, that it belongs to the ACCP. The recording belongs to the ACCP. You're welcome to invite your colleagues to look at it on our website. There's a small charge, if a $10 charge, if people are non-members. Members get to see the recorded sessions for free. It's part of the core curriculum for correctional medicine, and which is what we're trying to do with these grand rounds. I'd ask you to use the chat, which I will be monitoring carefully for any questions that are coming up as we're going along. But Dr. Wimberly asks you to save most of those questions for the end and or put them in the chat, and we'll deal with them as they're coming up. And what else do I have to tell you? Our big conference is coming up in Salt Lake City, September 9th to the 11th. I encourage you all to spread the word about our national conference. It will be a wonderful conference, and I look forward to networking and learning with all of you during the course of that on September 9th to 11th in Salt Lake. And I think there's probably something I'm forgetting, but I don't know what it is. If you are a non-member and you wish to make a donation to the ACCP for the CMEs, that's welcome, but there is no charge to anybody for this or for the CME. If you want to support us and the expense of obtaining the CME, all the better. And I've said enough, I've talked enough. Let's just get on with it. I've been looking forward all week to hearing Dr. Wimberly speak. And if you have anything else to say about yourself, please do so, because I will admit that I don't know Dr. Wimberly. This was through this presentation is through the kind assistance of Dr. Stapleshorn, who most of you know, who did the recruiting and the arrangements and everything regarding this. I was hoping she'd be here so I could thank her in person. At any rate, thank you very much. And go ahead, Dr. Wimberly.
Okay, thank you very much. And I am so excited to be with you. And I'm impressed that you guys are taking your evenings to do grand rounds. Very impressed. So hopefully by the end of this, you will feel that this was an hour well spent. And so I want to just tell you a little bit about myself. I am a pediatrician, adolescent medicine specialist. So I see patients between the ages of 12 and 26. I am one of the physicians at Children's Healthcare of Atlanta, the Hugh Spalding campus in Atlanta, Georgia. Been there for 25 years, as well as a Grady Health System, which is a safety net, public safety net hospital in Atlanta. We have, it's about a 100-bed hospital, and we actually receive all of the we receive all the patients from the correctional facilities in the metro Atlanta area and have a special unit. I've been practicing medicine now for about 26 years. I was with Morehouse School of Medicine as a senior associate dean for clinical affairs and GME, where I provided oversight for the residents. And in addition to that, I was a staff physician with one of the Metro RYDC, so one of the Metro Youth Detention Centers, for about 8 years. And that's how I met Dr. Michelle Stapleshorn. And I used to bring medical students as well as residents there. I was one of the medical doctors there for about 8 years. So very familiar with the system and have worked in the system for quite a while and continue to be at a health system now that is really the only provider in the Metro Atlanta area on most occasions for our patients that are incarcerated. So that's just a little bit about me. I came into this position as the SVP and Chief Health Equity Officer at Grady after getting out of academic medicine about 18 months ago. So been at Grady for 26 years, but in this role came out of academics and kind of shifted over into the hospital administration and the C-suite. And so I've been doing this for about 18 months, and it has actually been a great change for me and something that has really been eye-opening. As an MD, I will tell you that it's different being in this position as an MD. A lot of my colleagues are non-MDs. And as an MD who has practiced medicine the majority of my career, or really nearly all of my career in inner city health and correctional medicine, it is definitely an opportunity for us to really hit the ground running and be very, very, very action-oriented in what we do. So today, I want us to kind of just review some of the goals and objectives. We want to understand some basic concepts of health equity and why it's important in correctional medicine, and some potential issues. We want to expand that value proposition of health equity to an organization's vision, mission, culture, strategy. We want to demonstrate how health equity will contribute to a significant quantifiable impact on patient care and clinical outcomes, as well as clarify some routine and practical solutions for individuals. I do anticipate that this presentation, for the first 30 minutes or so, I'm going to kind of get through some of the slides, but I did want us to have a big chunk of time to have a discussion about it. You guys are the experts. And I want to kind of get your thoughts and opinions on health equity as it relates to correctional medicine. And if you guys have any questions about that as well, I'd love to have a robust discussion with you. So the first thing that I want us to do is to kind of take a trip down memory lane. I think we have to understand where all of this came from. Health equity or diversity, equity, and inclusion are really words that people are using a lot these days, like a lot. And I like to kind of stop and just go back to the beginning and go back to the origins and where it kind of all started so that we can see where that evolution came from. Healthy People 2010 was one of the first places that started to note disparities when they talked about including differences that occur by gender, race, or ethnicity, education or income, disability, and living in rural areas and sexual orientation. So as you can see, it was a very simple definition, didn't have a lot of words, and pretty much kind of was based off of a lot of your demographic information. Then if you look to the left, I've compared 2010 to 2011. And then in 2011, we had things that were added to that, such as incidence, prevalence. We started to see mortality. We started to see burden of disease. We started to see other health conditions that were really added to that definition. So just within a 1 year period of time, there was a lot of evidence that came out about disparities, a lot of research that looked at, what were some of the causes of it to make that definition actually change somewhat. Then if we look in Healthy People 2020, which is one of the latest ones with the CDC Healthy People 2020, we see health disparities still, but we start to see preventable, buzzwords, preventable. Then we also start to see violence comes in, right? Optimal health. But then also this word called socially disadvantaged, which is really one of the first times that the CDC started to coin that term about social disadvantage, which really talks about social determinants of health, which we'll talk about in just a little bit. So just looking at how that evolution came. Now, when we talk about social disadvantage, it means restricted ability to participate in society, for whatever reason. A lot of times it becomes unfavorable economic or either political conditions that systemically, that's that word we start to see that systemically. And I would say that in our incarcerated population, that would be a population really that has a lot of social disadvantage related to a lot of things with the social determinants of health that we'll go through. So when we define what does health equity mean, it is defined by everyone as having a fair and just opportunity to be as healthy as possible, right? To be as healthy as they want to be, to be their optimal health. And that's important for us to understand, is it's not how healthy Dr. Wimberly wants them to be. It's their optimal health outcomes. So what I'm going to do is have you guys just take a second, and in the chat, I'd like for you just to kind of put down, what is your definition of equality? If you had to say what equality was, and Dr. Westbrook, I'll see if you can, I can't see the chat on my screen,
Oh, no.
but if you could just kind of let me see some of the stuff that folks are putting in there.
Okay.
Just what's your definition of equality? There's no need to go and do like a word search or anything out on the internet. Just kind of what pops in your mind.
We have somebody from Puerto Rico who is in everyone treated equally, as one person says. I'm gonna throw in mind the same opportunity for all.
Okay.
I'm having my own trouble there. The ability to succeed, something, the
Okay.
same treatment for all.
Equally. Okay. And then I see equally. Okay. All right. Perfect. All right. Now, what is your definition of equity? Put that in the chat for me, please.
So
What is your definition of equity?
defining equity.
Okay, so we have the same. Oh, I don't know if that was from earlier. I think that was from earlier. So if we talk about what is your definition of equity? Anybody? Okay, I don't see anything in the chat. Do you? Okay.
Equity and equality are confusing. Equity is equal opportunity, building goodwill from generation to generation.
Okay.
Reasonably, I said reasonably similar in opportunity, fair and impartial.
Okay. Good, good. Thank you for that. And I really do like that. The person who said that it sometimes can be confusing. We'll talk about that in just a second. Okay. The next question is, what is your definition of health equity? You have probably said it. We hear it all the time. What does health equity mean?
I'm going to put something in the chat rather than speaking out.
Okay. Just take a stab at it. Okay, providing the same to all, okay? Equal opportunity for resources, getting equal treatment for the same disease. Okay, all right.
I like that one. Dr. Rodriguez from Puerto Rico says, everyone has the opportunity to attain their highest level of health. Equal access, that's really important.
Mm-hmm. Okay, so now what I'm going to do is I'm going to show you my next slide. I want you to tell me how many of you, and you can just write, you guys know how to do reactions. Just raise your hand. You can just raise it in real time. How many of you guys have ever seen any version of this slide before?
No.
Or you could do reactions if you don't have your camera on. Yeah, thumbs up.
I love
okay.
this.
Okay, so a few of you have. All right. So now what I want you to do in the chat, tell me which of these, A, B, or C, which of these pictures, first of all, which of these pictures is the definition of equality? Would you say would represent equality?
Oh, I love
which of these
this.
pictures, A, B, or C? Just put it in the chat for me. A, B, or C, which
Quality.
one would represent equality?
Okay.
Okay, I see. Okay, I see. Okay. Let's see, I see a couple C's. Okay, which one,
Honestly.
A, B, or C would represent equity? Okay, we have a couple A's. Okay, okay. Now, which one of these pictures, A, B, or C, would represent reality? Okay, so
Okay.
this is really important.
Yeah,
So I'm gonna pause here and we're gonna kind of dissect this a little bit. Now, if we think about this, the outcome in all three of these pictures that are the same, they just have different boxes on them. The outcome is for everyone to be able to see the ball game, right? At the end of the day, everybody wants to see the game. Now, what we have is we have three different people. One has a purple shirt, red shirt, blue shirt, but they all want to see the game. That's the outcome. So the purple shirt is short, the red shirt is kind of middle height, and then the blue shirt is tall. So in these scenarios, what you would look to see is what are the things that are needed to ensure that they all can see the game. If we look at equality, you guys stated that C was equality. It is. Equality, everybody has one box, right? Everybody's on one box, everybody gets the same thing, but everybody cannot see the game, right? Everybody's outcome is not the same. Only one person cannot see the game, the other two can see the game. If you look at equality, everybody's getting the same thing, but we are not having the same outcome. So that's key. Everybody gets the same, but you do not have the same outcome. Let's go on over to A. If we look at A, that represents, as you guys correctly identified, that represents equity, which means that you are giving individual, you have to have that word individual in there in the definition. Each individual receiving the resources that they need to have optimal outcome. And in our instance, we're talking about health, right? So you're giving each individual the resources that they need individually to have an optimal outcome. So if the outcome was to have to see the ball game, the purple shirt got 2 boxes, the red shirt received 1 box, and the blue shirt did not need a box. And they all have the same outcome, but they have different levels of resources. And then if you look at the reality, of course, this is sometimes what people may feel as far as the distribution of resources just in society in general, that some people have lots of resources, exposure, experience. Some people kind of are born behind the 8 ball. And then some people just have just a little bit, depending on, and this could be because of your socioeconomic, it could be because of where you live, it could be your schooling, you put it in there, it could be anything. So that's really the concept of health equity that I like to show, because it's really simple to understand this way, to look at what that outcome is, and then what it is that we're giving people. Now, let me ask you this. Somebody tell me in the chat, or you can come off of mute and tell me, what do the boxes represent?
Resources.
Resources, like what?
Money.
Money, what else?
Access to care.
Okay.
I'm going to be quiet.
Insurance.
Would you say health insurance? Okay, what else?
Education.
Education. Transportation. So when you think of all the programs that we do, all the wraparound services that we provide, those are the boxes. Those are the boxes that help people to come to a certain outcome.
Safety and security. Yeah.
Right. So let me ask you this. With the boxes, who determines how many boxes they get? That's a little bit of a rhetorical question. Who determines it, right? It might be just one person who's determined it. It might be that it's written in the grant, you know, exactly what you can give, but somebody is determining if that person got 2 boxes or 1 box or 3 boxes. The third thing I want to say to dissect this picture is What if I took the box away? What if my resources went away, right? So I had a grant funded project, the grant went away, didn't get any more dollars after that. So I had to pull it out. I had budget cuts, I had to pull it out. I had someone quit, so that resource was pulled. So think about those things when you're talking about the boxes. And so as we talk about health equity and we think about it in society, I love thinking about programming and resources because that's the main thing people ask me every day. Dr. Wimberly, I got a good idea. We should do this. We should do that. We should can you write a letter of support? We should do this. But the thing is, if we don't change the system, the resources that we're providing, which is the programming and the wraparound services and everything else, are in most times temporary or conditional on something else. And so think about that. So until we really dig deep and not just stop at the level of programming, but start at the level of let's look in our communities to see what's causing this disparity or to see what's changing this disparity. One thing that we do at our hospitals, we have a food is medicine program. You guys have probably heard of those, right? So we bring people down to the hospital once a week and we give them a box of food. We pay for their transportation to come down to us. We give them a box of food that we put together, right? I mean, we just put something together, we gave it to them, and then we transport them back to their community. Imagine the amount of resources that it takes for us to do that. That's a lot to transport people down, get the box, and then transport back. What if we just went to the local grocer and said, hey, we want to collaborate and advocate for our patients to live in your community. And what we've noticed is that we need more fresh foods in the grocery stores around here. How can we collaborate with you to help to make sure that that happens? So the Miss Jones just has to walk up the street to get her fruit and vegetables. And I don't have to transport her 10 miles down to give her a box every Wednesday and transport her 10 miles back just to get a box of fruit and vegetables. So thinking about systemically, how do we change the things that need to be changed? You can take that and apply that to whatever type of medicine that you practice. We'll talk about correctional medicine in particular in just a bit, but taking that concept and thinking, what is it that we can do beyond just providing resources and or boxes to our patients, but actually make some significant systemic change? Because the only way that we're going to be able to beat this is to go into the communities, to change the communities. Because we as a system aren't really, our hands are tied as to how much we can change. Thank you for that. Hopefully you guys enjoyed the pictures, and if you've never seen it before, it definitely is very helpful in understanding. Now, just as many of you were kind of unsure when we ask you to write down the actual definition of something, so were a lot of folks that I spoke with at Grady. So when I first came, the first thing that my boss told me was, we got to have a definition, Yolanda. We got to have a definition of health equity. The second thing is we have to make a strategic plan. We have to write a strategic plan. The strategic plan had to be informed though. So I did listening tours. I went out and spoke with over about 250 people. And what we ended up doing was having small focus groups. And we asked people those same 3 questions that you guys answered. Those were the same 3 questions that we asked. Very simple focus groups, which generated a lot of discussion. And what we found in those focus groups, that only about 21% of the respondents even provided the correct definition of equity. And this went from our board of directors all the way down to our frontline workers, EVS staff. So we went to every level of management, which was 8 levels within the institution. And what we found, it was only 20% really even understood what that was. And what that told me as the leader in this space is that we've got to make sure that we understand, and we have to teach people the foundational principles of what we're talking about and how they in their everyday work can be ambassadors for health equity. And so it's important as you engage in this work, even if you decide to engage in this work within your institution, is to really understand, first of all, that you understand what it is. And secondly, that others in your organization understand, because otherwise you're not going to see the needle move. You're not going to have an impact. And some of that reasoning is because of the fact that people don't really understand how they can contribute to being able to be part of the answer. And this is our definition of health equity. We just adopted the Robert Wood Johnson definition of equity that states that everyone has a fair and just opportunity to be as healthy as possible. And it requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs and fair pay, quality education and housing, a safe environment, and healthcare. And so that was our definition that we adopted from the Robert Wood Johnson. Now, when you think about health equity, I spoke briefly a little bit about when we talked about that social disadvantage coming out from the CDC Healthy People 2020. And what you're looking at is those social determinants of health. And on the screen, what you see are different social determinants of health. And these are things that are going to determine your outcome. So when you look at social capital, education, employment, socioeconomic status, your food access, your transportation, your housing, your access to healthcare services, all of these things contribute to your health outcomes. And then when you look over to the left, what you see are things that a lot of time that are things that can lead to some of these social determinants of health. But even if you don't have any of these things that are listed to the side, the racism, the homophobia, the sexism, you still, with the ones in the middle, if you have a significant amount of social determinants of health that are disadvantaged, it can start to have decreased health outcomes for you or adverse. So let's just take a look at what some of that looks like, okay? So we know that about 20% of a person, socioeconomic factors are based off of healthcare, whereas about 80% of it has really nothing to do directly with healthcare. But we as health systems are expected to really manage that. So we know that 20% is healthcare, so that's going to be access to healthcare related. A lot of it is health behaviors, right? Diet and exercise, alcohol use, sexual activity, if they're using condoms or not, tobacco use, the physical environment, what their living environment looks like, if it's safe, if it has a lot of smog, thinking about environmentally, the climate, and then also their socioeconomic factors, such as their education status, their job status, family support, income, all of those things can be, and a lot of times it can really be traced back to not only just your zip code, but your neighborhood. Because the majority of zip codes have about 2 to 3 different neighborhoods located within them. And it's amazing how one zip code can have different life expectancies depending on what neighborhood a person is in. And so this graphic, I love it because it just shows how we, as in the medical profession, are really directly responsible for only 20%. But it is up to us to make sure that we're managing that 100% when we look at that whole person. So just to look at just some things really quickly, some of the sociodeterminants of health. This is looking at your wealth disparities increase with education. And, I had to really kind of look at this a couple of times because the title said racial wealth disparities increase with education. And you would think that it would say decrease. But this was a survey from Consumer Finances, the latest survey that they have out, which really looked at the educational level. So you're looking at less than high school, some college, and college. And then on the left-hand axis, you'll see just kind of from $0 to $450,000, just how much the median household net worth was by race. And with black being blue and white non-Hispanic being red, what you can see is with less than high school, what that disparity is. High school, some college, and then college. And so what it shows is that as the salary increased amongst both blacks and whites, the more educational level they had, the disparity of pay income actually got larger, which you would really think that would shrink and become smaller. And so these are things to really kind of think about, because we know that one of the biggest things that has to do with equity and disparities really does have to do with, as you guys mentioned, education as well as housing. So if we look at unemployment rates, over the past 50 years, the unemployment rate for Blacks and whites for Blacks has consistently been twice that of whites. Pick a year, any year. And it typically has been consistent that it's 2 times. And this is a slide going all the way back to 1972, all the way up to 2017. If we look to the right of the screen, what we'll see is that the unemployment gaps are widest for employees without college degrees. And so if you look at less than high school versus looking at college, you do see that there tends to be some decrease in that gap. But when you're looking at those without college degrees, that's going to be a key one. Then if you look at the socioeconomic status, and I'll help you read this chart, SES1 is going to be the lower, so the lower amount that you're getting paid, and then SES5 are going to be your higher paying jobs. And you look between white, African-American, and Latino, you'll see that 68% of Blacks fall within that SES1 compared to 12% of whites and 53% of Latinos. And so as you can see, when you're looking at that SES and you're looking at that race ethnicity, just that earning power of what you're bringing home is different. Then last but not least, when you look at ownership, we do know that wealth is truly based off of ownership. Owning your own home is a key indicator in what that looks like. And what we see is if you look at you see that the Black home ownership rate has not risen above 50% this century. And so in 2019, it was at 42%. It actually dipped a little bit in between 2009 and 2017. And then if you look at non-Hispanic whites, it has consistently been around the 70% mark. And so just looking at that, all of those things contribute to those social determinants of health, and as you guys correctly identified, will contribute to a lot of your health outcomes because of access to care, health behaviors, and those types of things, violence, those things. Now, I know how many of you guys have ever taken that Harvard implicit bias test? You guys taken that? Just put in the chat, let me know if you have. A lot of people have tried that implicit bias test. If you haven't, I would recommend that you just kind of take it just to see what all the buzz is about. But there's a test online. It takes about 15 minutes that a lot of institutions use. And what is implicit bias? Implicit bias is that automatic reaction we have towards other people based on past learning expectations, right? So it allows us to process things differently. It's that split second. And no one is saying that implicit bias is right or wrong. It is what it is. I think it's important for us to recognize it, right? So it might be that if I have had a bad or a good experience associated with something, when I see that thing again, it triggers either that negative or that positive feeling in me, right? And so thinking about implicit bias in that sense, and what does that mean? Now, you all are all correctional in the correctional medicine arena. So you're probably very well familiar with implicit bias, probably because of, just how people really feel about the patients that we care for on a daily basis. There's lots of implicit bias, I know, with that, especially when they come into the hospital system or when there's anything that has to do with their health or any type of decisions that have to be made around that. And so it's important for us to understand implicit bias and for us to understand how that works against or for us in certain situations. Now, how many of you guys have heard of this study that was just released in November of last year, but it really got a lot of press in February? It came out around Valentine's Day in the New York Times magazine, and it was a study of 2 million births in California. California was selected because it's one of the most populous states with the most populous births. And so went to California. It was the first study of its kind because it was done, it was actually done by a federal agency. And what they did was they linked birth to economics. which is one of the first things that the studies that have ever looked at it that way. And the upshot was that they found that childbirth was deadlier for Black families, even when they were rich. So if you can see these 4 bullets at the bottom, the richest white women had the least amount of deaths, maternal as well as infant deaths, prior to the first year of birth, despite the fact that the richest white women were the highest risk, because a lot of them had advanced maternal age as well as multiple births with IVF. Then you looked at the poorest white women had the second best outcomes. The richest Black woman had the third best outcomes, which was twice that of the richest white woman. And then if you look at the poorest Black woman, of course, had the worst outcome, which I don't think anyone was really surprised about. But what this groundbreaking study showed was a lot of times we think and we say, okay, well, socioeconomic status, education, people just make more money, live in a different neighborhood, then they can close that equity gap. But it really showed that it's not just about your resources. It's not just about anything else, that actually race, ethnicity may play a role in that as well. In that same study, they found that one doctor who had, they looked at comparative patients of a doctor who had both African-American as well as white patients, and just the differences in the outcomes by physician, as well as just by being treated at the same hospital. And so that was something that came out that was pretty big back in February. And I just wanted to just call your attention to that. Now, what I want to do is I want to stop for a second, because we're going to get specifically into the incarcerated population to see if there were any questions or comments on that first part.
Dr. Wimberly, oh, I'm
Yes.
sorry. Go ahead, Mike. No, I just wanted to make that comment that also came out in the news a lot with Serena Williams, and how she had difficulty, with the amount of money that she had, how she almost died because of really the physicians not listening to her and not hearing her complaints. So that study sort of crystallized what we had suspected. And certainly for our women that are incarcerated that fall primarily into the poor group, then they're always at risk of worse outcomes. But I know we'll talk more about our incarcerated populations later, but I just wanted to put in a plug for that as well.
Oh yeah, no, we're getting to that part now. And I see there was a question, how do you explain these findings in light of resources? And essentially what the article found was that it really wasn't about the resources, that it was about racism and how people felt. I mean, that's really what it was about. And there have been studies that have shown that depending on who the provider is, the race, ethnicity, and lived experience of the provider, if it is similar to that of the patient, that there are better outcomes. And so just really looking at that literature as well. So it was groundbreaking in the sense that it was the first study that linked those two together, maternal deaths, that linked it with your socioeconomic status, and looking at that. All right, so if we look at incarceration, you guys are more expert at this than I am, but looking at about 2.1 million adults were incarcerated in 2016, about 4 million on parole, and just about 2.5% of the population is under correctional supervision, with multiple jails nationally in the country. If we look at the inequities exist, of course, in the disproportionate incarceration rates. When you look at race, ethnicity, I'm really preaching to the choir. African Americans and Latinos are incarcerated at a higher rate than other race ethnicities. And then those disparities in all elements of the justice system, when you look at the whole gamut from arrest to sentencing, you know, they do have an effect on health outcomes. And one of the things that that was really interesting about looking at those outcomes that I don't think a lot of people look at is just the disruption that it causes to families and communities. You guys do it on a daily basis, so you see it. But a lot of people don't really think about that. You know, when primarily it may be a male that is removed from that household with that male role model, with that male just support system being there. And definitely, especially if there is a female, you know, that's involved when you look at your female incarcerated women. And so thinking about what that does to the family unit, also what that does to the socioeconomic status of that family, and also potentially really having more and more inequities that are present if you have someone that's incarcerated because a parent is away. And so thinking about how that affects those involved. And then personal agency is fundamental to health equity and healthy communities. And really being able to advocate for yourself, that is kind of taken away in our incarcerated population. People in prisons and jails, we know, are disproportionately likely to have chronic health problems, diabetes, high blood pressure, HIV, substance abuse problems, mental health problems. Some of them, and the majority of them, were probably present before incarceration, but also may become more relevant once they're incarcerated as well, just depending on the resources that you all have to be able to manage those different disease processes within the system that they're in. Because of that, mass incarceration has actually shortened the overall US life expectancy. I don't know if you guys knew that, but in the whole life expectancy calculated formula, when they look at the population piece of it, the more incarcerated folks that you have, it actually shortens the overall US life expectancy. And what this table, I thought this table was quite interesting to show the change in life expectancy and time to recovery. This was a study that was done in New York State that looked at the length of stay in prison by months on the left side, and then your change in life expectancy at age 30 years. And so as you can see, at if you were in prison for 18 years, it's a life expectancy change of minus 2.98, so almost 3 years less. And then your time to recovery, what that indicates is the time that it takes for you, once you get out of prison, to be able to really level set that back to what it was before. And so it may take 3 to 4 to 5 years to be able to level set that. I thought that was very interesting.
Are you talking about national life expectancy as well, for the whole country?
Mhm.
That mass incarceration has lowered that?
This study right here looked at New York State, in particular areas in New York State, but in the article they do extrapolate. But yes, in that formula, there is incarcerated is put into that life expectancy formula. It's a very detailed formula where they put a lot of things in there, like the death rate, the density, and things of that nature. Incarceration rates for that particular area are also included.
Well, it's remarkable to see that stated as such. I mean, I agree with it, but I've never seen it stated like that, you know.
I hadn't either. And when I came across it, when I was doing the research to try to find something different for you guys for this talk, I came across it and I had never heard anyone really speak of it before. There weren't lots of articles on it, but I am doing a new life expectancy table as part of a project that I'm doing for my position. And I noticed that the other day when I was recalculating the formula, that's one of the variables in the formula.
Well, I'm 86, so I'd like to hear your results.
Okay. Okay. Yeah. But you are definitely beating the odds.
Now,
Okay.
now if I can chime in.
Yes.
I've been a correctional medicine physician for 30 years.
Uh-huh.
And yet, the most terrifying thing I can think of is seeing red and blue lights in my rearview mirror.
Mhm.
And so maybe you should include the terror index of having false arrest and what that does to people's expectations too.
You said false arrest? Okay.
Because that changes your expectations of things too.
For sure.
Mm-hmm.
Yeah,
Now,
and go ahead.
uh-huh. I'm
I
sorry.
was on mute or not. I'm trying to move the people around so I can see the slides. But you bring up a good point, just the whole idea of trauma and how trauma impacts or the risk of trauma when you think about false arrest, when you're thinking about worrying about whether or not you'll be gunned down if you walk down the block to get fresh vegetables. So that whole trauma piece also comes into place when you look at the health inequities.
Mm-hmm. Definitely. And at this time, I just have one more, and then I'm going to open it up for discussion. This is something that I kind of came up with on my own, and I tried to think about, okay, as we're talking about looking at the pathway to health equity, what are some things that we need to take into consideration? So really just evaluate the situation, educate yourself, formulate a plan, activate that plan, and measure it to see if it's successful and if it has had a significant impact and is worth continuing on. So these are just some ideas that I have put in a slide that broke it down for me. So when I talk about, okay, what is my pathway to health equity? Access to quality care. When you think about your institutions, you know, the type of insurance that's accepted within the institution and what type of resources does that insurance allow? You know, charity services for us at Grady is a big thing. Appointment availability as well as wait times is another thing. Transportation and access points. So for you in the correctional medicine, it may be, you know, where is it that you have the ability if a patient is takes ill or has chronic medical illnesses, what's your backup? What's your support within your clinic, within your medical clinic? What is available for you? Are there limited medications that are available? You know, do you have limited access? You know, if an inmate is being monitored for chronic illness, are there enough physicians or providers there to be able to ensure that they are being monitored appropriately and at the frequency that they need to be monitored to, you know, to provide good prevention? So thinking about that access to quality care and what does that mean? Is it quality care, meaning that this is the best that I can provide at this particular point in time with the resources that I have? Or is it the quality care that I'm saying this is the best that, you know, society has to offer, and this is all that we have? A lot of times I've been at safety net hospitals pretty much my whole career. You know, it may be a combination of the two, right? Depending on their insurance status may really sometimes, unfortunately, decide the type of care and the quality of that care that can be provided within the restraints of what I have. And so looking at that access to quality care within your institution and what can be done to raise that and to ensure that that standard is available across all entities. Looking at screening and prevention services. And so do we have standardized screenings that we do in our correctional facilities? I know when I was with working with Michelle at DJJ, we had, you know, everybody came in, it was a standard, everybody got this. You know, some people got more, but what is there a minimum standard? And why do you choose those screening and preventative services? Are there others that you feel could be helpful and warranted, but you may not have the resources or supplies or dollars to be able to do those type of prevention and screenings? I have a question for you guys. Do you on a regular basis, when you're talking about screening and prevention, especially in your adult population, are you all doing screenings for like breast cancer, colon cancer, prostate cancer? You're doing that on a regular basis to eligible patients in your population?
We should be
Okay. Okay.
part
And
of
so
our standard, you know.
it's standard. Okay. I know for us as a hospital system, it's quite difficult. So I can imagine that, you know, there may be some difficulty with that really on the patients wanting to do it, as well as really having the resources to be able to say, okay, I'm going to screen all of my 45 and above year old males and females in the carceral system for, you know, colon cancer, you know. And so looking at what those rates do you guys keep those rates nationally? And are those publicized? Are that things that you guys talk about at your national meetings?
I haven't seen any. What about
No.
other people?
No, it's pretty disjointed. I mean, I think a lot of correctional health is really based on that solo providers' determination to try to have equity in providing the services for their patients and to be in an environment where they're allowed to do so. Because sometimes physicians may want to provide equitable treatment, but they're limited in resources or limited in by policies and a lot of other red tape that we have to deal with that, and even some we consider intrusion of medical autonomy. So it may be that, you know, security doesn't want that person to go out, although for additional services, although we know they should go out, you become, it's not like we are masters of the hospital, you know, and have the autonomy. When we are in a correctional setting, we're in that security's house. And so sometimes we're burdened with security rules that we have to figure out how to get around in order to get the care that our patients need.
Okay.
And it varies from one institution to the other.
Okay. Do we have anyone on that wants to talk about at their institution if they have been able to achieve some success in that area with standardization of screening and prevention services that are throughout all of the population that they serve?
Wait, so I'm going to speak up. I don't think we have any demographic data on health disparities by race, sexual orientation, or anything in the prison system. I really have never, and I put it in the chat, I've really never seen any data. And this talk for me is just raising so many questions, more questions, I'm afraid, than answers, in the sense that, so if you say, so a person walked into prison and a lot of them are Black, a lot of them are Latino, but I like to think that everybody gets the same services regardless, but I don't think I have any data that supports that it does happen that way or doesn't. It's just that I don't think there's any data out there about outcomes. You know, like that data that you showed us about poor, wealthy Black people are still under, I won't say underserved, but the health equity is just not there for even wealthy Black folk compared to poor white folk. And there shouldn't be any health disparities. There shouldn't be any health provision disparities in our prison system by race or by any other indicator, but I bet there is.
Yeah, and it'd be interesting to see.
I wish there were data.
I'm thinking for you guys, the type of prison. So if it's federal or state, or I don't know all the different kinds, but, you know, and you have the kind that are, you know, high security versus low security, minimum security. I bet even if you start to slice it and dice it that way, you may start to see that there's some medical service disparities too. Maybe your low minimum security prisons provide more, I don't know, I'm just kind of talking, thinking, but I think there's lots of avenues to explore. A lot of times too, when we think about correctional facilities, we go to HIV, we go to substance abuse, we go to STDs, and we kind of get stuck on that. But, we may say, okay, there's higher rates. Okay, there may be, right? But when do we ever talk about just cancer prevention stuff? Cancer prevention, simple things that for us in a hospital system, our biggest thing is getting people there to get the test.
We don't have that problem.
You don't have that problem. You have people there. So imagine if you could just
they can refuse.
Right. So what if you had like that built into your system where you had, a scope there to be able to do all of your colonoscopies, and you had a mammo machine, you had this and you had that. So I think that would be very innovative for you guys to really look beyond just what people typically think of, which is HIV, substance abuse, STDs, when they talk about correctional medicine. I used to hate it when I was working because everything was always so negative, right? It was always just negative. Or people would just say things that just didn't make sense. And so trying to flip that when we're talking about inequities, because you have a captive audience. If we wanted to change something, y'all are the place where the change can happen because you have a captive audience, right? I'll never forget when I was at DJJ and I had to come in and do a talk, and I was talking to the group of teenagers, and I said, so is everybody excited to be here? And they said, well, it's better than just sitting in the cell. I said, well, okay, I'm gonna take that as a yes, captive audience, right? Like, I don't know how to take that, right? But if we think about it that way, we could do some great stuff. When you're talking about screening and prevention services, you guys could lead the way in what that looks like. And like you said, Mike, you have a high risk population right there,
Yes.
And then the next thing you want to do is make sure that you measure your outcomes. Okay. And so looking at, okay, now that you got the data, we want to measure the outcomes, and then determining what your treatment options are, or what those, what would be available for that. And then somebody has something to say?
Good. I'll let you finish. I'll go ahead and go back.
Yeah, and then the last thing I wanted to say on this is really just kind of looking at a level of, I like to say, look at your staff, and look at your patients, and then the community around you. As you talk about inequities and disparities, looking at what that looks like, and how is it that you can utilize each of those in a positive way, to make a great impact. With staff, a lot of it comes with education and training, right? And understanding. And then with patients, it comes with just education as well as providing resources and services. And then community, of course, being a partner within the community, especially as you start to have like reentry programs and things of that nature, and educating your community about the system as well, and educating the patients about how do we transition you out. Now that you're getting out, how do I find primary care for you within the community? Do I have a doc that I refer everybody to? What is that follow-up? Do I have a hospital system that I help to connect you with so that your services can be continued? How do we have a program where we help incarcerated folks as they are exiting out of the system to be able to still have that insurance? I know a big thing that I've learned from Michelle a lot is just the insurance. So if you have Medicaid or Medicare, when you get out, what happens with that? Does it take you a while to go get the application, to get it set back up? So those types of things as well. the last thing, and how many of you guys have heard of this correctional medicine fellowship program? I think, okay, ACGME is going to be coming and speaking at one of your conferences, but I was one of the co-chairs, myself and Don Berwick, we were the co-chairs for the development of the program, and Michelle Staples Horn was one of our committee members, and it was really a labor of love, and we got out a correctional medicine fellowship program. It is now has a 45-day open period, so open comment period. So I have included on the last slide here on the ACGME website where you guys can go and read through the skill and content areas about the fellowship program and make comments to see if there's things you think we should add, something that we didn't get right. We had I think about 35 folks from different agencies within correctional medicine with input. And so these are just some of the skill and content areas that the fellowship program is going to address. And the purpose is to give those physicians who really do want to have some type of a concentration within correctional medicine, some extra training to ensure that we support them and provide them with all the things that they need to be successful in that program. And this is the ACGME, and if this is a hyperlink, so if you click on the hyperlink, it'll take you directly to the comment period. And the ACGME asked me to definitely let you guys know that, and they welcome any comments that you may have after review. And then the last thing I want to say is that health equity is not a footnote. It's not an add-on. It's not an afterthought. It's not something that's nice to do. It's not something you think about when challenged by the community, or the media. It really is foundational in everything that we do. And we should look at it as something that is embedded in our everyday thought process. And I'd like to ask you guys, how often do you assess how you're doing as far as just looking at disparities and inequities within your system? And, the biggest piece for me that I talk about a lot is until we get it as a performance measure, it's going to be really hard to have people do it on a regular basis. If you measure it, what doesn't get measured sometimes doesn't seem to be as important. And the last thing is, would you consider yourself actionable on health equity, and have you moved the needle within your system to make some changes to kind of close some of those inequity gaps? And so I will stop here.